Welcome you. Today we're gonna see about cardiovascular examination. This is Mohammed Suhail. Let's get started. A complete examination of all system is essential to detect peripheral and systemic effect of cardiac disorder and evidence of non-cardiac disorder that might affect the heart. Examination includes the following: vital signs, pulse palpation and pulse auscultation, vein observation, chest inspection and chest palpation, cardiac percussion, cardiac palpation and cardiac auscultation, lung examination including percussion, palpation and auscultation, extremity and abdominal examination is done. Cardiac auscultation is discussed in a separate topic. Despite the ever increasing use of cardiac imaging, bedside auscultation remains useful as it is always available and can be repeated as often as desired without cost. Vital signs include blood pressure, heart rate and rhythm, respiratory rate, and temperature. Blood pressure is increased in both arms and for suspected congenital cardiac disorder or peripheral vascular disorder in both legs. The bladder of an appropriately sized cuff encircles 80% of the limb circumference and the bladder's width is 40% of the circumference. The first sound heard as the mercury column falls is systolic pressure and the disappearance of the sound is diastolic pressure. Up to a 15 mmHg pressure difference between the right and left arms is normal. A greater difference suggests a vascular abnormality like dissecting thoracic aorta or a peripheral vascular disorder. Leg pressure is usually 20 mm of mercury higher than the arm pressure. To obtain an accurate blood pressure, the patient should be seated in a chair for less than 5 minutes, feet on floor, back supported. Have the limb supported at a heart level with no clothing covering the area of cuff placement. Abstain from exercising, consuming caffeine, or smoking for at least 30 minutes before the measurement is taken. Heart rate and rhythm are assessed by palpating the carotid and radial pulse or by cardiac auscultation. If arrhythmia is suspected, some heartbeats during arrhythmias may be audible but do not generate a palpable pulse. Respiratory rate, if abnormal, may indicate cardiac decompensation or a primary lung disorder. The rate increases in patients with heart failure or anxiety and decreases or becomes intermittent in the moribund. Shallow rapid respiration may indicate pleuritic pain. Temperature may be elevated by acute rheumatic fever or cardiac infection. After a myocardial infarction, low grade fever is very common. Other causes are sought only if fever persists for greater than 72 hours. Ankle brachial index. The ankle brachial index is a ratio of systolic blood pressure in the ankle to that of in the arm. With the patient recumbent, the ankle blood pressure is measured in both the dorsalis pedis and the posterior tibial artery, and the arm blood pressure is measured in both arms and the brachial artery. The index is calculated for each lower extremity by dividing the higher of the dorsalis pedis or posterior tibial pressure in that extremity by the higher of the two brachial arteries systolic pressure. This ratio is normally greater than 1. A Doppler probe may be used to measure blood pressure at the angle if the pedal pulse are not easily palpable. A low ankle brachial index suggests a peripheral arterial disease which can be classified as mild, moderate, or severe. A high index may indicate non-compressible leg vessels, as may occur in conditions that are associated with blood vessel calcification. For example, diabetes end-stage renal disease and Muckenberg arteriosclerosis. A high index may suggest that further vascular studies are needed. It is toe brachial index or arterial tube studies. Orthostatic changes. Blood pressure and heart rate are measured with the patient supine, seated, and standing. A 1 minute interval is needed between each change in position. A difference in blood pressure of less than 10 mmHg and a change in heart rate of less than 20 beats per minute is considered as normal. The difference in the blood pressure tends to be a little greater in the elder due to loss of vascular elasticity. Pulses paradoxes. Normally, during inspiration, systolic arterial blood pressure can decrease as much as 10 mmHg and pulse rate increases to decompensate. An exaggeration of this normal response with a greater decrease in systolic blood pressure or weakening of the pulse during the inspiration is considered pulsus paradoxus. Pulsus paradoxus occurs in the cardiac tamponade, constrictive pericarditis, severe asthma, and occasionally in chronic obstructive pulmonary disease. Restrictive cardiomyopathy, severe pulmonary embolism, and hypovolemic shock too. Blood pressure decreases during inspiration because negative intrathoracic pressure increases venous return and hence right ventricular filling. As a result, the interventricular septum bulges slightly into the left ventricle outflow tract, decreasing the cardiac output and thus blood pressure. This mechanism and the drop in systolic blood pressure is exaggerated in the disorder that causes high negative intrathoracic pressure, like in asthma, or that restrict right ventricular filling or the outflow. Pulsus paradoxus is quantified by inflating a blood pressure cuff to just above systolic blood pressure and deflating it very slowly. The pressure is noted when the Korotokov sound first heard and when the Korotokov sound are heard continuously. The difference between the pressure is the amount of pulsus paradoxus. Pulse. Peripheral pulse. A major peripheral pulse in the arms and legs are palpated for symmetry and volume. Elasticity of the arterial wall is noted. Absence of pulses may suggest an arterial disorder or systemic embolism. Peripheral pulses may be difficult to feel in obese or muscular people. The pulse has a rapid upstroke, then collapses in disorder with a rapid runoff of arterial blood. The pulse is rapid and bounding in a hyperthyroidism and hypermetabolic state. It is slow and sluggish in hypothyroidism. If pulses are asymmetric, auscultations over peripheral vessels may detect a brood due to stenosis. Carotid pulse. Observation, palpation, and auscultation of the both carotid pulse may suggest a specific disorder. Aging and arteriosclerosis lead to vessel rigidity, which tend to eliminate the characteristic finding. In a very young children, the carotid pulse may be normal even when severe aortic stenosis is present. Auscultation over the carotid artery can distinguish murmur from broods. Murmurs originate in the heart or great vessels and are usually louder over the upper precordium and diminish towards the neck. Broods are higher pitched and heard only over the arteries and seem more superficial. An arterial brood must be distinguished from venous hum. Unlike an arterial brood, a venous hum is usually continuous, heard best with the patient sitting or standing, and is eliminated by compression of the ipsilateral internal jugular vein. Veins. Peripheral veins. Peripheral veins are observed for varicosities, arteriovenous malformation, and shunts, and overlaying inflammation and tenderness due to thrombophlebitis. An AVM or a shunt produces a continuous murmur and often a palpable thrill because the resistance is always lower in the vein than in the artery during systolic and diastole. Neck vein. The neck vein are examined to estimate the venous wave height and the waveform. Height is proportional to the right atrial pressure and waveform reflects event in the cardiac cycle. Both are best observed in the internal jugular vein. The jugular vein are usually examined with the patient reclining at 45 degree. The top of the venous column is normally just above the clavicle. So the venous column is elevated in heart failure, volume is overloaded, cardiac tamponade, constrictive pericarditis, tricuspid stenosis, and superior vena cava obstruction or reduced compliance of right ventricle. If such conditions are severe, the venous column can extend to jaw level and its top can be detected only when the patient sits upright or stands. The venous column is low in hypovolemia. Normally, the venous column can be briefly elevated by firm hand pressure on the abdomen. The column falls back in a few seconds, despite continued abdominal pressure, and however, the column remains elevated during abdominal pressure in disorders that causes a dilated and poorly compliant right ventricle, or in obstruction of right ventricle filling by tricuspid stenosis or right atrial tumor. Normally, the venous column falls slightly during inspiration as lowered intrathoracic pressure draws blood from the periphery into the vena cava. A rise in the venous column during the inspiration occurs typically in the chronic constrictive pericarditis, right ventricular myocardial infarction, chronic obstructive pulmonary disease, and usually in heart failure and tricuspid stenosis. Jugular vein can usually be discerned clinically but are better seen on the screen during central venous pressure monitoring. So the normal jugular wave, A wave is caused by right atrial contraction and followed by X descent, which is caused by atrial relaxation. C wave is an interpretation of the X descent. It is caused by transmitted carotid pulse and bulging of the tricuspid valve into the right atrium as it closes. It is seldom discerned clinically. The V wave is caused by right atrial filling during ventricle systole. The Y descent is caused by rapid filling of the right ventricle during ventricular diastole before atrial contraction. Abnormal jugular wave. The A wave are increase in pulmonary hypertension and tricuspid valve stenosis. Giant A wave occur in a atrioventricular dissociation when the atrium contracts while the tricuspid valve is closed. The A wave disappears in atrial fibrillation and are accentuated when right ventricle compliance is poor. The V wave are very prominent in tricuspid regurgitation. The X descent is steep in cardiac tamponade when right ventricle compliance is poor. The Y descent is very abrupt because the elevated column of venous blood rushes into the RV, that is right ventricle, when the tricuspid valve opens, only to stop abruptly by the rigid right ventricle wall or the pericardium. Next is chest inspection and palpation. Chest counter, chest counter, and any visible cardiac impulses are inspected. The precordium is palpated for pulsation and thrills. Inspection. Chest deformities can occur in a number of disorders. Shield chest and pectus carinatum may be associated with Marfan syndrome or Noonan syndrome, accompanied by pulmonic stenosis, atrial septal defect, or hypertrophic. Rarely, a localized upper chest bulge indicates aortic aneurysm due to syphilis. Pectus carinatum with a narrow anteroposterior chest diameter and an abnormal straight thoracic spine may be associated with hereditary disorder involving a congenital cardiac defect and sometimes Marfan syndrome. Palpation. Approaching the patient from the right side systematically, palpate the precordium with the patient laying at the approximately 30 to 45-degree angle. The apical impulse healthy individual should be palpable between 4th and 5th intercostal space, just medial to the mid-clavicular line, and cover an area of less than 2 to 3 cm in diameter. A central precordial heave is a palpable lifting sensation under the sternum and anterior chest wall to the left of the sternum. It suggests a severe right ventricular hypertrophy, occasional in the congenital disorder that causes severe right ventricular hypertrophy. The precordium visibly bulges asymmetrically to the left of the sternum. A sustained thrust at the apex suggests a left ventricle hypertrophy. Abnormal focal systolic impulse in the precordium can sometimes be felt in patients with a dyskinetic ventricular aneurysm. An abnormal diffuse systolic impulse lifts the precordium in patients with severe mitral regurgitation. The lift occurs because the left atrium expands, causing the anterior cardiac displacement. A diffuse and infralateral displaced apical impulse is found when the left ventricle is dilated and hypertrophied. Thrills are palpable buzzing sensation present with particularly loud murmurs. Their location suggests their causes. A sharp impulse at the second intercostal space to the left of the sternum may result from exaggerated pulmonic valve closure in pulmonary hypertension. A similar early systolic impulse at the cardiac apex may represent closure of stenomitral valve. Opening of stenotic valve sometimes can be felt at the beginning of diastole. These findings coincide with the augmented first heart sound and an opening snap of mitral stenosis heard on auscultation. Next is lung examination. The lung are examined for a sign of pleural effusion and pulmonary edema, which may occur with cardiac disease such as heart failure. The lung examination includes percussion, palpation, and auscultation. Percussion is the primary physical maneuver used to detect the presence and level of pleural effusion. Finding areas of dullness during percussion signifies underlying fluid or less commonly consolidation. Palpation includes tactile firmness, vibration of the chest wall felt while the patient is speaking. Firmness is decrease in pleural effusion and pneumothorax and increase in pulmonary consolidation. Auscultation of lungs is an important component of examination of patient with suspected cardiac disease. The character and volume of breath sound are usually in differentiating cardiac from pulmonary disorder. Adventitious sounds are abnormal sounds such as crackle, ronchi, wheezes, and stridor. Crackles and wheezes are abnormal lung sounds that may occur in heart failure as well as non-cardiac disease. Crackles are discontinuous adventitious breath sound. Fine crackle are short, high-pitched sound. Coarse crackles are longer lasting, low-pitched sound. Crackles have been compared to the sounds of crinkling plastic wrap and can be stimulated by rubbing strands of hair together between two fingers near one's ear. They occur most commonly with atelectasis, alveolar filling process, and interstitial lung disease. This signifies opening of collapsed airway or alveoli. Wheezes are whistling musical bed sounds that are worse during expiration than inspiration. Wheezing can be physical finding or as symptoms and is usually associated with dyspnea. Wheezes occur most commonly with asthma but can also occur in cardiac disease such as heart failure. Abdomen examination and extremity examination. The abdomen and extremities are examined for the signs of fluid overload, which may occur in heart failure as well as non cardiac disorder. Abdomen. In abdomen, a significant fluid overload manifests as ascites. Marked ascites caused visible abdomen distension, which is tense and non-tender to palpation, with shifting dullness on abdominal percussion and a fluid wave. The liver may be distended and the slight tender with a hepatojugular reflux is present. Extremities. In extremities, fluid overload is manifest as edema, which is swelling of soft tissue due to increased interstitial fluid. Edema may be visible on inspection, but modest amount of edema is very low. Obese or muscular people may be difficult to recognize visually. Thus, the extremities are palpated for presence and degree of pitting, the visible and palpable depression caused by pressure from the examiner's finger, which displaces the interstitial fluid. The area of edema is examined for extent symmetry, warmth, erythema, and tenderness with significant fluid overload. Edema may also be present over the sacrum, genitals, or both. Tenderness, erythema, or both, particularly when unilateral, suggest an inflammatory cause. Non-pitting edema is more suggestive of lymphatic or vascular obstruction than fluid overload. Thank you.